Hello, everyone. I'm Kathleen Morris, VP Research and Analysis at the Canadian Institute for Health Information, and I'm delighted to have a chance to say a virtual hello. I'm joined today by my colleague, Natalie Damiano, Director of Specialized Care. We've both been involved in a project that involved developing coalitions, collecting and connecting data in different ways, all in support of informing policy. We're excited to share our experience today and to have a great exchange with you. I know that there's been some polling questions up, and we'll look to see the answer. I know it's always difficult with some of these virtual connections. They're not quite the same, but we thought that some of the polling questions might give us a chance to understand each other a little better. And I'll just check, Natalie, can you see the polling questions?
I can see them, but they don't appear to have started. So,
well, that's okay. You know what? I think we'll have a chance to get to know each other fine as we go forward. And so I hope that that all of you are joining from a reasonable hour during the day. For Natalie and I, it's about 6 p.m. So we'll be looking forward to a good dinner after we're done this session. The next slide that we have is one of a park. Natalie and I are both from Ontario, Canada. And when we built this slide deck a few weeks ago, it was a beautiful fall day. And this picture, it really did look as beautiful as the picture shows. This is coming from a ravine right in the middle of Toronto. And I hope it inspires some of you from other places to consider putting Canada on your travel bucket list when we all get back to thinking a little bit about travel adventures. I love that it's also a picture of a bridge to show that even when we're not able to connect in person, we're so pleased that we have a virtual bridge to share learnings across countries and across disciplines. And we're very grateful to IPDLN for providing us with that forum. So we're both looking forward to the dialogue. So let's get started. First off, let's talk a little bit about KAHI. Our full name is the Canadian Institute for Health Information, but KAHI, as we're usually called for short, is a not-for-profit independent organization focused on health data and information. We have no legislative authority, but rather we try and present a compelling value proposition to governments. The top left corner of this slide highlights that aim: better data, better decisions, and healthier Canadians. And the three strategic directions are in the middle column, and that shows how we choose to get there. KAHI's jobs fall into three main areas: setting standards, collecting and enriching data, and publicly reporting on information. We provide context and frame issues, but we don't take policy positions or make recommendations. We've been around for a long time, over 25 years, and we receive funding from all 14 governments, which helps us feel that we're at least on the right track with that value proposition. So let's just flip, Natalie, to the next slide, which shows, just quickly for those of you who may be joining from elsewhere, that Canada is a big country by area, although most of us live in a small band along the US border within about 100 kilometers. So our population is actually, given the size of the country, quite consolidated. The accountability for healthcare, on the other hand, is quite decentralized among provinces, territories, and the federal government. If we flip to the next slide, we can see that the federal government's responsible for some distinct things: principles, regulations, services to certain groups, notably many Indigenous people, veterans, prisoners. The federal government also supplies regular funding transfers to the provinces and territories, and sometimes special financial incentives in areas of national priority. The provinces and territories, on the other hand, are largely responsible for operating the health system, managing quality, access, and costs. Healthcare is a topic of which Canadians are very engaged, And given it's an area of growing demands and costs, I think it's fair to say it's a relatively fraught space among governments. The project that we'll talk about today is one of those areas where the tension was evident in the early days. So if we flip to the next slide, we call this our Shared Health Priorities Project. And that's largely because in late 2017, all governments agreed on 2 areas where care needed to be improved. The first was home care. And as the population ages, more Canadians, mainly the elderly, need home care or services in the community to help them manage conditions and live safely at home. Canadians also needed timely access to mental health and addiction services, with mental health and addictions problems affecting many Canadians at some point in their lifetime. While there was agreement on the 2 sectors that were important and about the size of the money that would be involved, negotiations stalled because there was not agreement on how progress should be measured. This was a sticking point for a few reasons. Data infrastructure and performance measurement in these sectors was not well developed, and improving access to these services is not easy. It's likely to require new ways of coordinating services and navigating the system. KAHI was asked to come in at this point and build a coalition of stakeholders, develop indicators on the priority topics, and publicly report on these indicators for the duration of the 10-year agreement, which leads nicely into our objective for today's session. So this shows where we're trying to go today, and just take a look at an overview of some of the coalitions, the data, and the approach that we've taken, and hopefully we'll spark a good discussion on this and learn from each other. We flip to the next slide, Natalie. This just gives a little bit of a play-by-play of how we'll get through this. Natalie and I will alternate, and we'll each tackle a different aspect of the project. I'll start with a section on coalitions and consensus for about 10 minutes or so. And Natalie will get into indicator development for about 20 minutes. And then I'll come back at the end for a discussion on public reporting and whether the work is making an impact. In between Natalie and my sessions, we'll pause for a few minutes for questions, and then we'll leave lots of time at the end for more discussion. So moving on, let's get to the coalition piece, and we can go one more slide, Natalie, please. So we talked earlier about data coming into KAHI voluntarily being provided by the provinces and territories according to mutually agreed standards. So we use that data to produce indicators and reports, and again, with mutually agreed approaches. So mutually agreed sounds like an easy thing to accomplish, but actually it's quite a time-consuming and thoughtful piece of work. We do most of our work by assembling coalitions and making progress based on consensus, so it's one that's quite familiar to us. For a long time, we've worked with coalitions of governments, researchers, clinicians, measurement experts. More often now, we're also engaging with people with lived experience. That's a relatively new process for us, and we're getting better at it, but undoubtedly still have a lot to learn. These coalitions and collaborative processes are usually amazing experiences, and they get great results, but they often don't move super quickly. So you can imagine that a 6-month start to finish timeline, which is what we were given, was a bit heart-stopping for us, knowing that there'd been close to a year of government discussion that hadn't really been able to make progress. So if we move to slide 11, I always like to start with a happy ending. This says that we actually got to where we needed to be, and the health ministers all agreed on a set of indicators. So let's talk a little bit about how we got to that point. So we'll go to the next slide, Natalie. Thanks. So our general approach was to take the politics out of the discussion and replace it with some quite rigorous process. We had a multi-step mixed methods approach was used. It started with environmental scans of measures used to monitor access, and we looked both in Canada and internationally. From that process, we had a list of over 600 possible measures and indicators. So there's a lot to work with. So then we had to narrow that down somehow. So we had discussions about guiding principles for indicator selection, and then we had large groups come together to try and identify priority sub-themes within the areas that we were focused on. Next came a modified Delphi approach to evaluate indicators, and at this point we were looking at close to 200 indicators, and evaluate them using agreed upon criteria. And this engaged both the government representatives as well as sector stakeholders and measurement experts. At the same time as we were doing this, and if we just flip ahead one slide, Natalie, a public consultation occurred. And to do that, we used key informant interviews, we used focus groups, and we had online surveys. And these consultations, as you can imagine, were really helpful. They helped us understand and explore what did the public understand when you use the words access to services. We tried to understand as well as how the general public prioritizes some of the key questions. What's most on their mind when it comes to access? And we sought opinions, ideas, and advice from about how the indicator should be presented to Canadians. Through the focus group process, we talked quite a bit to people with lived experience, and they, I think, provided so much insight and a great kind of putting the color on the problem that they were experiencing. And I think the people from some of the other sectors, particularly the government reps, found that really very, very helpful in their decision making. And many of the things that they heard from people with lived experience really did, I think, at the end of the day, influence some of their views about where to go with the indicators. So the final decision making group consisted of leaders in federal, provincial, and territorial governments. They drew very heavily on the sort of data-driven quantitative results that came up from the Delphi process, but they were able to balance that with the public input. And as one of them said, it really helped put a human face and on the decisions that they were trying to make. So if you were a fly on the wall during those deliberations, I think you would have seen a great example of governments in action. All of the representatives had really taken their job super seriously. They'd learned a lot over the process, and they had a very good understanding, I think, of the needs of the people in both of these sectors. There was a lot of listening that happened. There was no bullying, and there was lots of circling back amongst the group deciding to understand concerns and reservations where they existed. And I think we really did have consensus on a package that had a good balance of indicators. So if we go forward one slide, Natalie, you can see that we actually ended up, the group was charged with picking 3 indicators in each sector. We actually ended up with 6 indicators in each sector for a total of 12. And I think we came up with more, partly because the group that made the decision was really trying to balance a number of different dimensions. They were looking for something on children and youth. They were trying to address palliative care and dying at home. They were interested in the experience of the clients and patients, but also of the caregivers. They were looking for, definitely wanted to include measurements of actual, wait times. They wanted something on addiction. So to get all of those needs met, the number of indicators chosen was larger. Just to kind of play out the chronology of this, the indicators were endorsed in March by the deputy ministers, the most senior officials in the public service from all governments, and then in June by the elected health ministers. We agreed to, you can see there's a sequence to the indicators. We agreed after the 12 were chosen to roll them out at a rate of 3 per year. starting with those that were more straightforward, where we could identify the data source, and leaving some of those that would definitely take more time to develop and that were more complex to the later years. I'm happy to share that the first 6 are actually out the door. The next 3 are well on their way, and work is happening in earnest on the last 3. So we're very, very pleased with our progress. So if you just want to move ahead to the next slide, Natalie. In terms of keeping the coalition going, I think that in terms of the government partners, I can't overstate the importance of frequent and transparent communication with our government partners. They are the data providers. They are the people who have to implement and live with the indicator results. And we always try to remember with that group that the partnerships are 2 ways. And in a good relationship, you don't let your partner go it alone. So we try and help them as much as we can after the data results are available by doing jurisdiction-specific briefings to support understanding and communication of results, helping them brief within their organizations, helping them understand from what we can see, why the results look the way they do, what the data can and can't tell us, and what are some of the key takeaways. In terms of the persons with lived or living experience, our objective the whole time was to be very cautious that our objective was to help and not harm them. So we try and make sure with all of the language that we use that we're not blaming the people who are ill or need help. We try and keep our indicators and our perspective and communication system focused rather than behavior focused. We also try and validate their experience. And I think bringing their viewpoints into things has been very much appreciated by all involved. The clinicians and service providers are a continuing part of the coalition, and they keep us grounded in the real world. And can tell us whether the data is representative of the way services are delivered. Do the data tell the real story? What else do we need to think about? And then finally, I guess the one challenge that all of us have dealt with in some ways is just this moving to virtual and how that's impacted some of the coalitions that we were trying to put together, particularly for some of the year 4 indicators. So it's hard, especially when the topics are quite conceptual and they need discussion and unpacking. But life goes on, so we do the very best that we can. And one interesting thing we did is we piggybacked on a virtual conference for one of the indicators, and we're very grateful to the attendees there for making time for us and working with us and giving us great input. If we think on the next slide, Natalie, a little bit about some of the success factors in terms of having a successful coalition. I think some of it is identifying the right people for the right type of work. So for our SHRP advisory committee, so the group that actually picked the indicators, for example, in the early days, we needed people who had, the full confidence of their senior leadership. And so we actually asked that the government reps be nominated by their deputy minister. So that they had the credibility and the decision-making heft that was needed in a difficult negotiation, and be able to speak to the indicator selection on behalf of their province or territory. As the process shifted, though, and the jobs of that committee shifted as they're trying to not just select indicators, but try and help navigate through the development of the indicators, the work changed, and in some cases, the right people changed as well. Sometimes particularly in large provinces, there are people who are more familiar with the sector file. So the key, I think, is just making sure that you're always revisiting who do you need around the table. Another piece I think that was really important was around having clear goals and being really clear on the scope and the partner responsibilities. So for example, each of our indicators has a specific expert advisory group that's formed. in addition, that sort of reports in through to the coalition. And these groups needed a clear terms of reference, their charge was not to revisit the indicators that were chosen and say they would like a better one, but it was really to give their very best advice on how to shape the indicators that were on the table. One of the things that we did early on in this that's been so helpful was to come up with guiding principles. So initially we brought those forward to support the decision-making around which indicators to select. But we've gone back to them so many different times as the project has evolved. So the guiding principles that we had were around things like flexibility in data collection in the early years, only reporting at a provincial territorial level until the indicators were more stable, trying to come up with some kind of a good balance between health system focused indicators and versus patient experience focused indicators. And I think those have really stood the test of time and have broken many difficult discussion and helped ground us on what we all are trying to achieve. A couple other things that have been, I think, useful to us. One of them is making sure that the people in your coalition, whether that be an expert advisory group or the actual main table, have enough information to give you informed feedback and response. And also making sure that they have enough time to get the information that they need, because I think nothing gets people backs up rather than feeling rushed to make an important decision. It's so important to get this process right so that the participation is meaningful and it's not just a checkbox. Everyone feels that they can really contribute. One thing that was also helpful for us in the early days is using an experienced facilitator. So for example, during discussions around which indicators to select, we at KAHI wanted to be an active participant in those discussions. So we needed to select a facilitator to ensure two things. One, that everyone was heard and felt like they were being heard, but also to drive us towards consensus. So it was a tricky mandate, and we had a good person to really help us out with that. And then the final part, and I guess this applies, at all lines of work, but I think it's really important to acknowledge and recognize contributions. Particularly at KAHI, like we are sort of at the end of the process, and we're the ones that are able to put the information out into the public sphere. But the success of the project is based completely on the hard work and the well thought through input from all of the people, all of the members of the coalition. And we check ourselves lots of times to make sure that we're always recognizing that effort throughout the process. So I think maybe what we'll do at this point is just pause for a few minutes for any questions that people may have or any feedback that they'd like to give us. And Natalie, I understand that you were the moderator in terms of seeing any of those as they come in.
Yes, I am. Can you hear me okay, Kathleen?
I can.
Okay. So I have one question here. I'm interested in hearing about the data and approach you will use for the navigation of mental health and addiction services indicator.
Mm-hmm. So that's something that we're working on right now. As we said, that we've started with the ones where the data sources were clearer, and we're sort of moving into evaluating the options for some of the year 4 indicators. Our sense is that it will almost certainly be a patient experience focused type of data. I think understanding navigation from the client's perspective is going to be the key to success of that indicator, but we're still in early days evaluating different data sources and exploring them.
I don't see other questions yet. We'll give people maybe another minute. Kathleen, while I'm waiting to see if anyone puts any questions in, just to let you know, about 60% of people, it's morning for them. And people have about a third of the people on the call have experience with public reporting, and about a quarter of people have experience establishing data standards as well as developing indicators.
That's great, Natalie. So it means that we probably have many of our colleagues from Australia and New Zealand joining in. And so that's great. And so if you catch us talking about too many Canada-specific things, we'll try and check that and make sure that we're explaining things clearly.
Okay. I have one more question that's come in, Kathleen. Can I ask how you got your lived experience participants, and did you specifically recruit individuals with mental health disorders?
Mm-hmm. So we had focus groups early on that actually did have people who were who had a family member often or themselves had received home care services, and at the same time we had similar groups with people who mainly it was people with lived experience with mental health and addictions. Although a couple of them were family members. So we had help from our partner organizations in terms of accessing people who would be comfortable and available to do some of that work, and that was very helpful. But yes, we did hear directly from people with lived experience, and it was clear from their discussions that they'd had many challenges with accessing services that were quite helpful in terms of really understanding the extent of the work ahead of us.
Okay.
Okay.
I don't see others, so perhaps we'll go back if that's okay with you.
Great.
I'm just going to go back to screen share. Give me 1 minute. Just give me 1 second, sorry. Okay. No, that's not. It's giving me some difficulty. Okay. Apologies, I'm just having difficulty getting it to share my screen. Okay, I'll try this again.
Oh, this looks good, Natalie.
Yes, it's coming along. Okay, we have success. Okay, so now I can continue. So thank you very much, Kathleen, for the first part of this presentation. What I'm going to do now in the second presentation is speak to the indicator development phase. So once all of the coalitions and the consensus building that has happened has occurred, and you saw the 12 indicators, or in many cases, indicator concepts that were agreed to or suggested, we then got to work on actually developing indicators. And what I'm wanting to do in this presentation is take you through KAHI's indicator development life cycle using one of the indicators from the Shared Health Priorities work as an example. And so this indicator we released just this past summer. It's one of our year 2 indicators. And it was based on the concept of an interest in looking at people who were admitted to long-term care who could potentially have been cared for at home. Okay. So as Kathleen outlined earlier, one goal of the indicator development work for Shared Health Priorities was to identify key indicators related to access to home care services. So we know within Canada that most seniors wish to remain at home for as long as possible. However, some seniors with mild cognitive or physical limitations get admitted to long-term care homes. In our data from a couple of years ago, we found that was represented about 45,000 Canadians were admitted to long-term care within our reporting provinces and territories. So that is not all of Canada, and as you'll see a little later in the slides, we don't have data from the whole country as of yet. So it represents a large number of people who are admitted every year. So if a certain percentage of them could potentially be cared for at home, it could be significant. So what we'll also like to do in this presentation is demonstrate how KAHI used standardized data from multiple sectors to develop the indicator. So before I move on, I do want to just stop and define long-term care. So in Canada, we use that term in nursing homes to mean residential type of care, so places where people are living other than their own homes, that provide nursing services 24 hours a day, 7 days a week. The average length of stay for individuals in this is the 18 months, and it's usually the 18 months prior to their death. As well, about 50% or more of people who live in long-term care in Canada are 85 or older. So we do have other levels of care that exist in Canada between home care, so living at home, and living in long-term care, such as assisted living or supportive housing. And they offer varying levels of support. In many cases, they're mostly private pay, although that varies a little bit across the 14 health systems that Kathleen referenced. So one of the things we really wanted to do in particular for this conference was illustrate a little bit of a different concept of linkage, where we were linking information across systems as opposed to linking individual records specifically. So KAHI has a well-established and rigorous indicator development lifecycle that is illustrated here. There's 4 phases, and I'm going to walk you through all 4 phases in the presentation. So in this first phase, we complete an initial investigation. So this is after the work that Kathleen already described in coming to the actual ideas first. We then took that information and really dug into it further to understand the problem we were trying to solve, to scan the environment for existing work that we could build on, to assess the data that might be available, and to review the information to ensure alignment where applicable. So in our particular example, the interest was really in, again, looking at residents in long-term care who could have been cared for at home. And KAHI had actually completed previous work in this area in 2017 related to seniors in transitions, and that ended up forming the foundation upon which we built this indicator. In the report we released in 2017, it was designed to really better understand how Canada's seniors transition from living independently to receiving continuing care services, be that at home or in assisted living settings along the continuum all the way to long-term care, and what factors might influence their transition to long-term care settings. The analysis examined a number of questions, which included how many seniors who entered long-term care might have been able to be supported at home, as well as what are some of the key factors that influenced that entering into long-term care. And in that report, we found about 1 in 5 seniors admitted to residential care could have been cared for at home or supported in the community. Some of the concepts and considerations in the initial report were broader than our current focus of access to home care services, and I'll go through those as I continue with the development life cycle. So in the second phase of indicator development, we use all of the gathered information and intelligence to develop our indicator definition. And to do that, we needed to make some decisions about what concepts we would include and exclude. We also needed to seek expert advisory input, and this goes along the lines to what Kathleen was discussing in some of the earlier phases. In this case, for this specific indicator development, we had 3 distinct groups that we sought advice from. We had a group of experts from across the country with really research and policy experience in this area. We also had a set of focus groups that looked at clients and caregivers with lived experience, as well as our overall advisory council for our full portfolio of shared health priorities work that Kathleen addressed a little earlier. And so using this process, we were able to refine our methodology, ensure that it's relevant to the audience and addresses some of their key questions. And I'll take you through some of the specifics that we did now. So in this case, one thing we did was we refined our indicator to really focus on those newly admitted. So what characteristics do residents have when they're first admitted to the long-term care home? And that was seen to be very relevant and actionable from our policymakers. So things that if they knew we could look at when you're starting to do admission applications, et cetera, that might help to identify people that could be steered outside of long-term care for a certain period of time. We also focused on identifying clients who could live well at home. So that doesn't, and not necessarily in other transitional environments like assisted living or retirement homes, as we recognize that the availability and access to those was varied considerably across the country. So in Canada, we have reporting systems that we maintain at KAHI for both home care and long-term care. And both of them actually use a common clinical assessment standard, in this case, the INRI assessment, which is part of a suite of assessments. In these INRI assessments, and there's other common assessments that might be like this, when a question like cognitive impairment is asked, the same sets of questions are used across the different sets of the sectors within the continuum, so between home care and long-term care, which really allows us to then look at the information across the system and see what kinds of similarities or differences there might be in clients or residents. So these assessments are used at the point of care to assess the clients and residents, to plan their care, to identify risks, and to monitor outcomes. And then that data then flows to KAHI within our reporting systems, and we're able to report it back to the people who send it to us, as well as report on a number of indicators and measures, both publicly and to our stakeholders. We were able to leverage that common assessment standard for this indicator development, and we created a sample of home care clients that were living well in the community, and we identified their clinical characteristics, and then applied thresholds to long-term care residents to identify those who could potentially be cared for at home. And on this slide, I have one example on the right. And so this is looking at clients or residents who are performing personal care or activities of daily living. And a higher score towards the right of your slide are for those who are completely dependent, and a lower score would be people who are independent. So you'll see the distribution in purple are people receiving home care, and the majority of clients in home care are reasonably independent in these activities of daily living, whereas the distribution in the bluish color is in long-term care, and you can see that more people need considerable help in activities of daily living and long-term care. And so we were able to draw that orange line that you see and suggest that perhaps some of the people with those scores of 0, 1, or 2 that look a lot like people in home care might be people that could be cared for at home. Through that exercise, we were able to determine which home care clients were living well in the community without an excess of service hours. So one additional piece of criteria that was important was people, in order to understand that they were living well at home, we looked for people in home care that had been on home care service for at least 180 days and remained on home care service for another 180 days after that assessment that we looked at. So they weren't people who immediately needed to be admitted to long-term care after we looked at the assessment. They were also within the 80th percentile for personal support worker and nursing hours. So they weren't receiving the top amounts of those. And that the client and caregiver did not think that the client would be better off elsewhere. That's one of the assessment questions. So with all those criteria in place, what's on this slide shows you the clinical profile. So people with no more than mild cognitive impairment, as well as limited assistance in personal hygiene, toileting, locomotion, and eating. And the things in brackets are just the actual outcome scales that exist within the INRI assessment. So the scores for those, for any of you who might be familiar with them. Also, we looked for people who had no falls in the past 90 days, as well in the 7 days prior to the assessment that they weren't experiencing wandering or physically abusive or verbally abusive behaviors. So all of that information allowed us to come to the definition and rationale for the indicator, which is listed here. So it focused on that percentage of newly admitted long-term care residents who could have been cared for at home with good home care supports. And the rationale is also listed here. So with this particular indicator, that interest of how does this talk about access to home care services, it allows us to look at, first of all, a lot of people, if they prefer to be at home, they're likely having a potentially better experience if they're remaining at home, as well as it makes sure that access to long-term care homes are available for residents with more complex healthcare needs. So as part of this indicator development phase as well, I said we were going to speak to some of our different stakeholders. So what we heard from that expert input was from that expert advisory group, really making sure that there was clinical relevance and providing jurisdictional context. So that importance of the variability in transitional environments, the effect of rural or remote environments, and you'll see that in some of the data as I start to show it to you. Because as Kathleen pointed out, while the majority of Canada lives very close to the US border and in very populated areas, we do also have some very rural and remote areas that end up having an impact on indicators like this. And from our residents and caregivers, as well as their families, we heard there were a number of barriers to remaining at home. So these included challenges navigating the system. So this wasn't just, it could be things like knowing where services were available, but also managing and coordinating all of it, coordinating all of the appointments for your loved one. It could also be financial barriers where there was limited availability of publicly funded care. And we also heard about the reliability of home care staff. So appointments being changed constantly in many parts of our country, bad weather for a good chunk of the year, which could end up with cancellations, as well as flexibility in evolving care needs. And then lastly, separate from sort of home care or what we might think of as home health or nursing services, there was challenges accessing social services. So that could include social and emotional support for the client or caregiver, as well as help with non-medical needs such as language and cultural needs. So once we were able to finalize the definition, we then got into calculating the results, summarizing some of our key findings, and making that data available. I think this is an interesting piece when we talk to the building coalitions. We really learned in our indicator development over the years that making data available in a preview period for our stakeholders helps to make sure that they can understand and share their results. We can receive feedback and adjust any key messages or contextual information that might be needed before we release it publicly. And in our experience, that's really helped jurisdictions prepare. It's helped generate strong support for the information that we release publicly. And it also aligns with a no surprises release strategy, which is one we often employ. So looking at our actual results, we found that about 1 in 9 newly admitted residents to long-term care could have potentially been cared for at home. These residents were more likely to live alone, as well as live in rural and remote areas when compared to other residents newly admitted to the homes. Similar to other residents, 2 out of 3 were women and over 50% were 85 or older. When we release our indicator information, we break it down in this case to a comparative view across the provinces and territories. So in this slide, you'll see that the overall Canada rate was 11.5%, or that 1 in 9. And then to the right of that gray circle, you'll see the provinces and territories for which we have data. So we don't have information from all. So we have British Columbia, Alberta, Saskatchewan, Manitoba, Ontario, Newfoundland and Labrador, and the Yukon Territory. Also on this slide, you'll see dotted lines for the provinces where we have partial data coverage and not complete. And then we have color coding. So provinces are assessed as being same as average, above average, or below average performance compared to that national average. And so blue is for same, green is above, and pink is below. What you can see in this case is there is variation across the country. So when we heard from our jurisdictions and our policymakers early on that they wanted things that were actionable, the variation suggests and helps to support the idea that there is potential to change because it doesn't look exactly the same all the way across the country. So there's opportunity to learn from each other and understand what might be going on. One important caveat on a slide like this is only one indicator, and it's important to look and consider it in the context of other results and information to get more complete picture, a balanced view of performance. So for example, at the same time that we released this indicator, we also looked at the percentage of the amount of caregiver distress that existed amongst people receiving home care and their caregivers. So those two might balance each other in an interesting way when you start to look at that data. So as we get towards the close of this, when we release, we obviously, in addition to that data preview, do provide an embargo period. We also provide a number of different products that help, so the technical notes, companion products, and a lot of the contextual information that's needed. In this presentation, key to this cycle is then evaluating that indicator. We're really just entering that phase now for an indicator that we released this summer. And to some of the guiding principles that Kathleen spoke to earlier, there is the sense that some of these indicators may evolve over time. And as we start to get more data from different provinces and really understand the indicators better. So that evaluation is yet to happen at this point. So in summary, I wanted to share a unique approach to indicator development that focused on linking information we have from multiple sectors across the continuum to answer a specific question. The approach demonstrates the advantage of consistent data standards across the continuum, in this case, the INRI assessment, and the leveraging of that common standard to allow for those linkages. In our indicator development, we address the unique challenges of having 14 different healthcare systems across Canada with different policies and care options that need to be considered. And really all with a goal to start a conversation on access to home care support and the role of long-term care in the continuum. So with that, I'm going to stop sharing. And Kathleen, just to check that we're on track for having time to look to see once I get to that screen if we have some questions.
Yeah.
Okay. So I see some questions, so I guess I'll read them out. I'll read them out to myself, Kathleen, and then answer. The technical challenges are interesting for these things. I wonder whether it would be useful to look at this stratified by sex and by prior living arrangement. Informal care available is likely to be a big influence to the ability for people to stay at home longer. It would be good to disentangle this from system barriers. So yes, thank you. That's a great question. This indicator does actually have some risk adjustment, which includes sex as well as people who lived alone. So it does get adjusted for some of those factors, because as you've pointed out in this question, that informal care availability is critical in identifying some of those barriers. So we do have some of that, and the details of some of those are all available in our technical notes for the indicators for anybody that might be interested. Could I please ask whether you applied a falls risk screen as part of the algorithm to identify individuals who could have been cared for at home, not just whether or not they had a fall in 90 days? So in our case, we actually looked specifically at falls. There are other assessment criteria within the assessment that get at some concepts of falls risk. I would say the most likely are some of the things like wandering, which was again a factor, cognitive impairment, and some of the physical impairment that limits people's ability to do functioning on their own. And then we added in the previous falls, because previous falls is one of the strongest predictor for future falls in terms of some of the data. So we don't have a specific screen, but it does get captured in some of the other factors that would be considered, I would say. And thank you for sharing your falls screen. I will definitely have a look at that. And then another question. We're okay, Kathleen, for one more?
Yeah.
Have one more? Okay. Really interested to see that the average length of stay is around 18 months for individuals in long-term care. I don't know the stats in this field in Australia or elsewhere, but I feel like it would be longer. Do you have international comparisons? I don't have them close at hand. I would have to look. I don't know, Kathleen, if you do. I know in Canada that number has been going down fairly steadily in the last decade in terms of, and that's with a few things, like there's quite a bit more availability of assisted living, supportive housing, retirement homes. So a stage that occurs between living in your own home and living in long-term care. So one of the things we notice when we want to look at international comparisons is that gets tricky around the world as to what we're defining in some of those different buckets. But be happy to connect afterwards with regards to some of those comparisons. I don't know, Kathleen, if you have anything to add on from your experience on that one.
No, other than you're 100% right, is that the numbers have been, the length of stay numbers have gone down dramatically over the last 10 years.
Okay.
Yeah. Okay.
I'm not seeing other ones come in, so Kathleen, I can pop the slides back up.
Sure. And while you're doing that, I'll just say that we'll bring it home with a quick overview of reporting and the impact that this work is beginning to have, and then make sure that we have some time at the end for even more discussion. And when we think about reporting, and maybe as you get that rolling, Nat, we'll just go a couple more ahead. That's a perfect one to land on. I think there's really three different ways that we meet our charge, again, from this work, is that it was not just reporting, but it was actually a commitment to share the results with Canadians. So we have three routes that we use to get there. So the first that you see on the far left of the screen is the one that Natalie showed you some of the results for the long-term care indicator, where it shows, some infographics, some factoids. It's designed really completely with a public audience in mind, and we often repurpose that on our social channels. Then if you go all the way to the far right, this is a contextual report, and it contains a whole lot more detailed information. It's really important document for governments, for the health system, but we try, don't know if we're 100% successful, but we try to write it in a way that it should be useful or interesting to a very interested member of the public. The report has guidance on how to interpret the indicator results, clarifies where the data is limited, describes some of the factors that influence the results, such as age groups most effective, rural, urban, some of those things, and really tries to provide some clarity about what the indicators can and can't do. So again, that one, it serves as a record of progress and insight for the intergovernmental agreements, but we know that there are people who are very deeply interested in this, so we make that publicly available. What we also have is something kind of in the middle, which is what we call our web stories that you can see in the middle of the screen. So it's designed for the media and a public who might want a little bit more information. So it combines the pictures and factoids from the first approach with a little bit of the context and guidance in interpretation that's in the contextual report. So it's kind of the middle ground between the two. And Natalie, if you just want to flip to the next slide, these just show a little bit of what the first purely public site looks like. And what we've done in this site is grouped all of our indicators, our new indicators under this project are just grouped under an access tab. So for governments, they care that it's under a shared health priority intergovernmental agreement project. But I think for Canadians, they're just more access indicators, and that's what they want to see. And one more slide just shows again, these are just some more of the kinds of pictures that we use. And again, we've had some good success building up social channels, and so we use those quite a lot on social as well. So if we go just a little bit further, we can just talk a bit about the work with the media and why, if our job is to report to the public, why are we focused on media? And I think that some of that is, like this slide just shows from our last release, which was in the doldrums of August, we still had some quite good media pickup of the stories. And you can see these are all prominent, mostly newspapers from across the country, but you can see the local issues are different. And people, like all three of the indicators had good media coverage in different markets. And I think there's a couple of reasons that we do that. One of them is a lot of the public get their information through the media. So it's a good way to try and get that message out. The other thing is that I think that the media is one mechanism that can support policy change. And that's the last topic that I just like to touch on a little bit. If we look to the next slide, there's lots of different ways which these new indicators could potentially influence policy. It could be around making access to services a higher priority. It could be a regulatory lever, enabling provinces to be compensated for virtual care might actually expanded the range of services that could be offered via home care, for example. Or it could be a funding policy initiative, so targeting more services. We're just talking about the challenges of the rural demographic, and maybe that's an area that you could focus more energy and funds. Or it could be information campaigns, for example, to promote what help might be available to the 1 in 3 caregivers who say that they're in distress. So if we flip to the next slide, so these are kind of theoretical different ways you could have policy impact. I think it might be helpful to just look at one of the indicators that came out early in the process, which was harm from substance use. And there was a couple of indicators that address that. And And one of the things that our analysis underneath that showed is that while there's been, rightly so, lots of attention in Canada over the last several years on a very serious opioid crisis with a high death rate, as well as on cannabis, which was recently legalized in Canada. But our data on substance use harms really highlighted that alcohol remains a very big contributor and responsible for a huge number of hospitalizations and emergency department visits. And it highlights the importance of alcohol as us, as we're thinking about policies. And we can actually point backwards now that this indicator has been out for a couple of years to policy initiatives where they've cited the indicator as an influence. For example, during, just go, I think, go forward. Oh no, this is perfect. Thanks, Ellie. No, we're good. Back to, sorry. But you can just see some of the areas that showed up with, in terms of looking at alcohol-related policies. So one of them is interesting is during our COVID lockdowns, many things closed, but alcohol sales were deemed an essential service. And that was made because there was a lot more understanding that substance use disorders, particularly around alcohol, were quite prevalent. And the decision was it was better to keep people with alcohol use disorders safe from withdrawal, which might in turn reduce demand for scarce hospital beds in an already strained healthcare system. And the second thing that was, where this indicator came into play is in the Yukon territory, which has some of the highest rates of harm from substance use. And they actually looked at some of the policy levers that they had available, one of them being the hours that liquor can be sold, and are just looking now through their legislative debates at putting in new regulations around that. There's other things that have happened where people have used the indicator as a stepping stone to kind of look at alcohol policy. So there's a group called the Canadian Alcohol Policy Evaluation Group, and their recommendation to people is to use KAHI data to measure the effectiveness of some of the alcohol policies that are in place. Another group that's part of our coalition, the Canadian Council on Substance Use, is doing a review now of Canada's low-risk drinking guidelines to see if some of the thresholds there need to be adjusted. Other things that are being put in place are around primary care screening for alcohol. What we saw from the Commonwealth Fund survey that shows that Canada has Canadians have great conversations with their family doctor in terms of many things around preventive health, including tobacco use. So 3/4 of Canadians say that they have a conversation with their doctor around tobacco use, but only 15% say that they ever discuss drinking with their family doctor. So I think that that's very interesting. And we've seen also that some of the governments, particularly in one province, have developed quality standards for problematic alcohol use. And sometimes the impact goes even beyond policy. And on the next slide, you can see another organization that we do quite a lot of work with, the Canadian Foundation for Health Improvement, where they've been looking at quality improvement initiatives and have sort of established these collaboratives where they can try and find innovations in the mental health and addictions and home and community care spaces where people are improving access, and they can help spread and scale some of those and really support the innovators, which is great, and hopefully a really productive consequences of having these indicators out. So if we flip to the next slide, which just kind of talks a little bit about what's next in this project. So we have to get to work on those last indicators. So I think we've got year 3 kind of under control. The year 4 ones some of those are quite tough ones. And in some cases, we're sticking with in some ways with the same approach. We're using multiple methods. We're including people with lived experience. We're having continued reliance on coalitions, even though those coalitions are evolving. But there are some pieces where the work may be new. So we're looking at data sources, and that was a great question that came earlier, where we're exploring, focus groups and qualitative research, surveys, whether they be traditional models or crowdsourced surveys, and just trying to think of different ways that we can get the data that we need to get to work on those indicators. I think we're keeping like a lot of the key elements. So in terms of evaluating those new potential data sources, we're looking at relevance, feasibility and sustainability, coverage, cost, how comparable things are across jurisdictions, the ability for data linkage. And I think we're also keeping a really close eye on Canada-wide standards and the need for really strong engagement of the coalition to move these challenging indicators forward. And I think we've had some good success so far, and I think that success is really kind of motivating people to kind of get us over the hump at the end. And then finally, on the last slide, I think it's just saying that there's a full suite of indicators that there's sorry, the phone's ringing of all things. But I think as we get this full suite of indicators, we're going to be able to tell a great story, I think, about access to care in these two sectors where before very little was known. And hopefully we've started our reporting at a provincial level, mainly, to get as much data out as we can to start with. But I think we're going to start looking at, as we get some over the hump with these indicators, whether we can get to a more local reporting level that would be helpful. And I think we'll probably be looking at the impact of COVID-19 on access to care in these sectors and some of the indicators as well. But our job is just to kind of keep rolling with this, making sure that we support our coalition and the use of the indicators by learning exchanges and working with the research community to try and take these further and hopefully achieve the improvement that was the quest at the very beginning. So we'll wind up there. We have some time for questions. And I think I'm actually now seeing some questions. And one of them is a comment really that's talking about how it's the importance of working with the media to make sure that it sort of takes work to a fabulous place to get the work out to the public. And another interesting comment that came, Natalie, connected to your presentation earlier around the average length of stay in long-term care in Australia is about 2.5 years. So it is a different, definitely some different results than we're seeing in Canada. So we're both very happy. Yeah, very happy to take any other questions that people have or suggestions that they have for us. I'll just give people a moment to see if there's anything that they'd like to capture as we get nearer to the end of this session.
Kathleen, I see one that looks at preference. I'm not sure if you see that one. Nope. It's asking, thanks for sharing these interesting results. My question is the preference for these older people. How are we going to incorporate this? And that's a very interesting question, and I think leads to some of the, not specific to this one, but a future indicator we have in the next couple of years is looking at the idea of people wanting to die outside of hospital and lots of conversations about preference around that. We didn't specifically get at preference in the indicator I spoke to today, going mostly on some of the large scale sets of information that do say that the majority of Canadians would prefer to remain at home as long as possible. But that obviously factors in, and it's one of those ideas that indicators really are something that points us to a certain thing. They don't tell the whole story. We need to look at that context, and clearly preference needs to remain as one of the options for people when they're making decisions about being admitted to long-term care.
Yeah, it's an interesting question because that came up quite strongly from the group when we actually selected the indicators. especially around the death at home one, because there was a very clear sense that we didn't want to just assume that that was everyone's preference, and that was the right place for all people. So it was a tricky one to work out, and I think we still have lots of working out. So if you have ideas for us on preference, or if you have done work with indicators that incorporate that kind of preference, that would be really interesting for us to learn from. Okay, so we'll just give people another moment just to see if there's anything else that they'd like to ask or suggest. And if not, I'd just like to say a huge thank you to you folks for bearing with us. We had a bit of a few technical glitches at the beginning, so I'm so glad that you stuck with us and were patient. It's always a privilege to be able to exchange work, particularly both with people at home and people in other countries, because we benefit greatly from the different approaches and the different experiments that have been tried in different jurisdictions in Canada, and also, of course, in different countries. And I think that's where all of us get the most from, that kind of creativity and exchange. So a huge thank you to the IPDLN organizers for letting us have a good conversation across many time zones, and to all of you for being part of the discussions today. Natalie, anything you see coming in there?
No, I think just a thank you, very interesting work. And I'd like to echo the thanks, Kathleen, that you shared as well. While we are not in Australia, it's great to still be able to connect with people around the world for this presentation.
Okay, well, in that case, we will give you your 5 minutes back. I'm sure you can use that in your busy day. And thank you so much. This was fabulous. Goodbye, everyone.